Namaste. I am Gaurav from the Faculty of Physiotherapy and Diagnostic FP in the Department of Diagnostic and Community Health in the discipline of radiology. Today we are going to discuss about the session that is important for general radiation second and radiographic technique of whole body for BScRT second instrument. I am from Vidyapeeth University. Okay. So, Namaste. Namaskar over here. In the previous session, we had discussed about shoulder epic projection. Next, now we are going to discuss about the shoulder lateral lateral view, the supine lateral scapular view, and the oblique AP view is a modified lateral shoulder projection view, often utilized in trauma imaging. Orthogonal to the AP shoulder view. Okay, it is a person projection to the assessed suspected dislocation, scapular fracture, degenerative injury. Okay, degenerative injury. Okay, this projection is best suited. This projection is best suited to trauma patients who are not on spinal precautions. Okay, for patients on spinal precautions that require a lateral shoulder radiograph, see modified supine lateral shoulder. Okay, so what is the indications behind this projection? The supine lateral view is performed to identify dislocation and scapular fractures when patients are unable to stand. Or sit for shoulder imaging, but able to roll while being supine. Okay, if patients are unable to roll, the modified supine lateral view can be performed. Okay, so the patient position, patient is supine, the fracture side of the patient is rolled anteriorly, roughly 40 degrees, or until the scapula is perceived to be end. On this is aided by placing a 45 degrees sponge under the rolled side. If possible, the affected side hand is placed across the thorax for additional rotation of the scapula into the lateral plane. Okay. So now the next point is a principal factor or exposure factor. It is a lateral projection centered on the level of the glenohumeral joint at the center of the proximal humerus. Okay, the straight tube to avoid elongation of anatomical structure. The collimation. Laterally to include the skin margin. Medially to cover the entirety of the medial scapula. Superior to the skin margin. Inferior to the inferior angle of the scapula. Orientation portrait. Detector size 8 by 10 24 by 30 centimeters. Exposure factors are 55 to 65 kVp and the MS is 10 to 20 ms. That is SID 100 centimeter. Grid, yes, grid is used with variation. Image technical evaluation. The radiograph should have a similar appearance to the PA lateral scapular projection. However, to correct the image is opposite to the PA. Okay, the scapula is clearly demonstrated in a lateral profile, giving a clear appearance. Okay, acromion and coracoid process from the upper arm of the shoulder. In intact, the humeral head is superimposed at the base of the shoulder. Okay. Fractal body. Lateral scapula projection can be technically demanding, especially when patients are in pain. And uh, anecdotal method amongst the radiographers is to feel for the medial border of the scapula and line it up with the anterior portion of acromial process and X-ray straight down the line. Okay. The idea being, if they are lined up, there will be a superimposition of the medial and a lateral border of the scapula, and hence a perfect lateral position, although this is not always the case. Okay. The best method against positioning error is having a true understanding of radiographic anatomy and how it changes positioning. When assessing for under or over rotation of the lateral shoulder, assess the border of the scapula. So, uh, so in this session, we had discussed about the shoulder lateral view. It is also indicated for for indicated for uh, mm, indicated for degenerative changes, any fracture, any dislocation, or any type of trauma injury that can be seen in the lateral projection. So in the previous session, we had discussed about the shoulder AP view or AP projection. In this session, we had discussed about the shoulder lateral projection. Both projections or the techniques of the views are important to evaluate the structure, anatomy, and aligning structure with the shoulder, any type of pathology, fracture, dislocation, any type of degenerative changes that occurs at the joint. So it is very important. These views are very important for evaluation of any changes, any type of fracture, any type of injuries in the shoulder joint. So, thank you. I think this session will help you to in positioning and technique. Okay. I think you will get good knowledge after studying, after listening the video, seeing the video. Okay. Thank you. Okay. Namaste. Namaskar, Vidya. In the previous session, we had discussed about the forearm, AP, and lateral view. In this session, we are going to discuss about the elbow, AP, and lateral view. Okay. So, elbow, AP, and lateral views technique and the X-ray position. That is the part of the radiographic technique of full body course in the BScRT second term. Okay. So, let us discuss about the elbow, AP view. Elbow AP view is a part of the two-view elbow series examining the distal humerus, proximal radius, and ulna. Okay, distal humerus, proximal radius, and proximal ulna. Okay, the projection demonstrates the elbow joint in its natural anatomical position, allowing the adequate radiographic examination of the articulation of the elbow, including the radiohumeral and humero-ulnar joint. Okay. Radiohumeral means articulation of radius with humerus, and a humerus with ulna. Okay. Indications. Indications. This view is clinically indicated for trauma, chronic discomfort, or infection of the elbow joint. Okay. It aids in visualizing fracture and or dislocation of the elbow joint. In addition to osteomyelitis and arthritis changes, it is a preferred projection to assess the medial and lateral epicondyle of the humerus for avulsion type fracture. Okay. Patient position. The patient is seated alongside the table. The fully extended arm, so fully extended arm and forearm forearm in a supinated position. Okay, fully extended arm or forearm in a supinated position. Okay, okay, are kept in contact with the table by lowering the shoulder, okay, joint it to the level of the table. They all must be in the same plane as the detector. Okay, the detector is placed below the elbow joint. Technical factor. The exposure factor or technical factor, it is an anterior posterior projection with lateral projection centering point mid elbow, which is approximately to the midpoint between the epicondyle. Okay, between the lateral or medial epicondyle collimation. Superior to the distal third of the humerus. Distal third. Superior to the distal third of the humerus. Okay, distal third of the humerus, or inferior to the include one third of the proximal radius ulna. Okay, okay. Lateral to the include, okay, lateral to the include the skin margin. Okay, medial to the include medial skin margin. Orientation. The orientation should be in portrait. Detector size 8 by 10 inches or 18 by 24 centimeters. Okay. Exposure factor that is used in the elbow is 44 to 50 or 2 to 6 elbow MAs 44 to 50 kVp. Okay. SID source to image receptor distance should be used in 100 centimeters. Okay. Grid. No, there is no grid used because of less factor use. Image technical evaluation. The elbow is in an AP position with slight internal rotation. Okay, AP position with slight internal rotation. Okay, with slight internal rotation. Patient's arm should be rotated externally. To ensure that the trochlea and capitulum are seen in the profile. Okay, in the positioning or in the projection. Up next is the practical points. At times, patients may not be able to fully extend their elbow joint. In such cases, partial flexion may be used at the joint. At initial presentation, two AP views may then be required. The first with the forearm flat against the detector, and second with the humerus flat against the detector. Okay. So lateral elbow view is part of the two views elbow series. Examining the distal humerus, proximal radius, and proximal ulna, it is deceptively one of the more technically demanding projection in the radiography. The projection is an orthogonal view of the AP elbow, allowing the examination of the ulna, trochlear joint, coronoid process, and the olecranon process. Okay, it is used to assess both the anterior humeral and radiocapitular line. Okay, the indication. This view is clinically indicated for trauma to the chronic discomfort or infection of the elbow joint. Okay, it aids in visualizing fracture or dislocation to any articulating bones of the elbow joint. Okay, in addition to osteomyelitis and arthritis. Okay, the visualization of the posterior pad sign on a true lateral projection indicates an elbow joint effusion and is suggestive of an occult fracture if no obvious fracture is seen. The tail sign or the triangular appearance of the elevated anterior pad should also raise suspicion of an occult fracture. Okay. So the patient positioning. Patient is sitting next to the table. Okay, inside the table at 90-degree elbow flexion. The medial border of the palm and the forearm are kept in contact with the tabletop. The shoulder, elbow, wrist are kept in same horizontal line as like elbow AP. Rotate the hand, show the thumb is pointing to towards the ceiling, ensuring all aspects of the arm from the wrist to the humerus are in the same plane. Okay. So the technical factor, it is a lateral projection. So the centering point, lateral epicondyle of the humerus. Collimation, superior to the distal third of the humerus, inferior to include 1/3 of the proximal radius in the ulna, anterior to include the skin margin, posterior to include the skin margin. Orientation, landscape, the landscape cassette is used. Detector size 8 by 10 inches or 18 by 24 centimeters. Exposure factor that is used is 44 to 50 kV and the MES 2 to 6 mm. SIT 100 centimeter is used, and the grit, no grit is used because of less factor use. Okay. It is also any technical evaluation factor point are same as like algorithm. So it is also performed for any type of injury and proximal radius ulna or distal humerus, or any type of elbow joint injury, or any type of fracture dislocation you can see in this after taking this treatment. Okay, thank you. I think you are satisfied with the session. Thank you. The session is over. I think this session is very much useful for you, or very interesting for you. I think you are satisfied with this session. If you have any queries, then put it into the comment box. I will resolve it later. Thank you. This session is over. This session is powered by Digital version 2.0. Vidyapeeth Women's University, Jaipur.